Okay, well, good evening, everyone, and welcome to this Cancer Vanguard showcase event looking at faster diagnosis. I'm Jenny Scott, and I'm the Programme Director for the Cancer Vanguard in Greater Manchester. And for those that aren't familiar with the Cancer Vanguard, we're a 2-year programme of innovations in cancer care. And the Cancer Vanguard nationally comprises 3 partners: Greater Manchester, University College London and Royal Marsden. So what we're hearing tonight is some of the work that we're undertaking as the Greater Manchester part of that Cancer Vanguard. And the main focus of the Cancer Vanguard is in 3 key clinical areas, and that's in prevention, in early diagnostics, and also living with and beyond cancer. So tonight is part of the early diagnostics suite of projects. And in a moment, I'm going to hand over to colleagues who will start the presentation and take you through that. We just wanted to say, this highlighted, we've got colleagues from Bolton, both the CCG and the Trust, and this is a really sort of innovative piece of work focused on how to streamline the referral of patients through to the right place so that we get a faster diagnosis and onto the appropriate pathway of care. Each month we focus on a different project, so hopefully if you find tonight interesting, you'll be checking out our website for all future events. We hold them on a monthly basis and we hold them strictly to 1 hour, so we will aim to have presentations till about 5:45, 10 to 6, and then you have about half an hour's opportunity to ask any questions or thoughts that you've got regarding what you've heard tonight. We do write up each showcase and we put it on our website. We also take photographs because we like to capture, you know, the discussion and capture the people who are attending these. So if you're not happy with having your photograph taken, then just please do indicate. And I believe we're also live streaming to the nation or the world even. For those that can't attend, this is being live streamed. So we want as many people as possible to hear about our work. So I think that's all I wanted to say, and I'd like to hand over to Lisa to take you through some initial housekeeping. Thanks, Lisa.
Thank you. Hello and good evening. I'd like to just start off by introducing the team, if I may. So I'm Lisa Galligan-Dawson, the Cancer Manager at Bolton NHS Foundation Trust, and for this project I'm the Implementation Manager. I'm joined today by my 3 colleagues. So Martina Kingscott. Martina's our Clinical Nurse Lead for Endoscopy and Bowel Cancer Screening at Bolton NHS Foundation Trust. And Martina has led the improvement work in the colorectal pathway. I'm joined by Melissa, who's our colleague from the CCG. Melissa is the project manager for faster diagnosis. And unlike most organisations, we've got a really, really close working partnership over cancer. So Melissa and I work together on all elements of cancer. So this project is something that we've run as a joint initiative. And we're also joined by David, who's representing the user involvement group. David and his colleagues very kindly supported us with patient information and guidance on the design of the pathway. So David's joined us today to talk a little bit about that element of the pathway as well. So we'll do the boring bits first. There are no scheduled fire drills, so if the alarms go off, we will need to leave the building. Anyone that needs a comfort break, the loos are at the back of the room to the right-hand side. We've discussed about picture taking, so if everyone's all right with that, that's great. Presentations will be circulated afterwards, so no formal requirement or need to take any notes. And if you've got a phone or a pager, if you could put that on silent, that would be great. So Melissa's going to start off just telling you a little bit about how we set up the project and its aims and objectives.
So the Fast Diagnosis Project is part of the early diagnosis family of projects within the Cancer Vanguard. And in the early stages of planning this project, we've been linking in with other projects in that family, such as the vague symptoms and ACE2 work, just to ensure we weren't duplicating work, but at the same time we were linking in to join up those pathways. We were awarded £120,000 by the Cancer Vanguard to support a 1-year pilot, and we also topped that up with £80,000 locally through our Locality Transformation Fund as part of the Greater Manchester Health and Social Care Partnership. terms of the project team, we have joint leadership from Bolton FT and the CCG, which has really helped us foster a collaborative approach with this. And it's really meant we've had joint buy-in from both organisations, that we've been able to have a really honest relationship with some of the challenges and to share the achievements as well. That's been supported by clinical leadership from both primary and secondary care, and that's been really important in supporting us to mobilise consultants and also our GP colleagues throughout this work. And the core team also works with all our existing teams in service delivery in the 3 tumour site areas. So that's included operational management, nursing staff, and also booking, coding and admin staff who have played a crucial role in being able to support us being able to monitor and to ensure patients are correctly referred onto the new pathways. So in terms of the aims and objectives, this project originally grew out of a bid that Bolton put into the NHS England Find Out Faster programme. And our feedback from that was that even though we put in a very strong bid, we were unsuccessful in achieving investment in that. However, the Vanguard saw a lot of potential in the project and the relationship we had across Bolton, so supported us in investing to trial a similar project here. The key aim of the project is to confirm to a patient whether they have cancer or not within 28 days of referral on the suspected cancer pathway. And for us, the key benefits that we wanted to test was patient experience in terms of reducing the amount of time when they have that uncertainty as to whether they have cancer or not. And also to give them a little bit more thinking time about what treatment options they may want to pursue. And also to look at what marginal gains that earlier diagnosis may have on the rest of the pathway in terms of 31 and 62 days. And a key part of all the Vanguard projects is to ensure that we're monitoring and evaluating the pilot so that we can share learning with other areas, both in Greater Manchester and nationally, so that hopefully we can do the hard work for other localities and they may be able to adapt this model. So for our project governance, we have used existing governance where possible. So for example, the groups down the left-hand side, such as the divisional boards, the strategy and planning groups, they were already groups we had in place in the division to support this project. We've also had a clinical steering group set up which has appropriate senior representation to ensure we've got buy-in at a very senior level to drive this forward. We report into the Vanguard team as well through their normal processes for other projects. And then we also have specific project groups set up for each project area to drive forward those. And Lisa will tell us a little bit more about why we decided to focus on those 3 areas.
Okay, so I'm going to talk to you about lung and upper GI. We chose 3 pathways for the project. We chose lung, upper GI and colorectal. And there were very specific reasons we chose those pathways. All of them are complex. All of them have a range of diagnostics that mean that patients have to undergo a number of tests, and that's sometimes across a number of different organisations. So we chose those tumour sites because they're complex. So if we can deliver this in these tumour sites, in the tumour sites where diagnostics is more straightforward, so the likes of skin and breast, we felt that it was easier to adapt to those more simplised pathways than it was to try and upscale to complex areas. And we chose those 3 because they represent the complexity of pathways across multiple organisations. So for example, with the colorectal pathway, that's a pathway that we can deliver in its entirety at Bolton if the patient's on a surgical pathway. So from referral, outpatients, diagnostics and treatment under that one organisation. The lung pathway is different. The lung pathway, the patient is retained by Bolton for its overall care, its overall communication, its overall support, up until the patient is transferred for the treatment element of the pathway. So this is a pathway that represents the complexity and the diversity across Greater Manchester. And within that pathway, patients go to at least 3 organisations for its diagnosis and treatment. And then finally, the upper GI pathway. And it's notoriously a complex pathway. It's notoriously a challenging pathway to deliver within 62 days. So was an obvious choice for us in terms of improving that pathway for patients. But it also represents a different style of pathway in Greater Manchester. So for Bolton, those patients come in and have their initial appointments and their diagnosis, so the diagnostics that will actually provide a diagnosis for the patient, so an OGD and a CT. And once the patient has got a confirmed cancer diagnosis that's been discussed at the MDT, the patient's care and support is transferred to another organisation. So these three pathways demonstrate the different types of pathways we've got across Greater Manchester. So for us, it gave us the opportunity to show if we can make this work, and we can make it work with these pathways, we should be able to make it work anywhere. So we'll start off with the lung pathway. And this slide just highlights the changes that we've delivered, but I want to just set the scene, if I may, around the current referral process. So if you're a patient at the moment in Bolton who has a chest complaint and you are worried and you pitch up at your GP, the normal process for a GP who suspects that the patient may have cancer would be a first-line diagnostic of a chest x-ray. The patient would then be given a card with open access to go and have a chest x-ray at their convenience, walk in, but at any point over the coming weeks. The patient's results are then returned to the GP. The GP would then bring the patient back into the surgery, give them the results, and if it is an outcome that is suspected of having cancer, the patient would be referred under a suspected cancer referral, which is known as a 2-week wait referral, into the hospital. That appointment is then created for the patient to either attend an outpatient appointment or to attend a one-stop clinic where you would have an outpatient and a CT scan at the same time. But for some patients, that would be an outpatient appointment followed by coming back for a CT. So that's the current pathway. What we're introducing at Bolton is an expedited pathway based on that initial referral for a chest x-ray. So GPs in Bolton will now refer patients for chest investigations as opposed to a chest x-ray. For the majority of patients, they will simply go back to the GP because it won't be anything serious and it'll be followed up as normal. But for those patients where cancer is suspected at the point that the chest x-ray is reported, those patients will be retained by the hospital and automatically listed for a CT scan. So overall, when you cut out the time to go back to the GP, the time to refer in, the time to appointment and the time to CT, that should save around a 3-week journey for the patient. But what it also saves is potentially around 3 other appointments for the patient to have to go to the hospital or go back to the GP. So it's a better pathway for the patient. It's not to and fro-ing, and actually it means that they've got quicker access to diagnostics. One of the crucial things as well at the minute, when patients are referred for a chest x-ray, it just says go for a chest x-ray because for the majority of patients there's nothing sinister within that. But actually for those where it is, if you've been and waited 6 weeks for your chest x-ray, that could have a detrimental effect. So part of the process of reviewing this has been to encourage patients to attend early for the chest x-ray, and we've given some time frames with the support of David and his colleagues in designing that information. We plan to go live with this pathway from June. It's just going through its final approval process at the CCG, but everything is ready and good to go. Obviously, it's a massive change to pathways. It's a different management of patients, different accountability of the pathway, and so it's taken some time to make sure that we've got the right support mechanisms, the right communication with GPs, and to make sure that patients are safeguarded in that process. But we are hoping to go live in June. What we've also done is redesigned the follow-up and the results process. For the patient, it's really important we get them in for their early diagnostics, but what's also really important is that we don't then have a delay in the middle of the pathway. So at the moment, patients would come back to clinic to get the results. But part of the project and part of where a lot of our investment is around that support for patients. So this is an expedited pathway, so you might have turned up from your GP with having a cough, and very quickly you're in a cancer pathway and being seen at speed. So there's an element of needing to manage the patient through that experience. So the results process will be via our specialist nurse, who will be the ones that advise them that they then need to go on for some further specialist investigation. So that'll be the cohort of patients that would go on for a CT, PET CT and an EBUS. So those patients would be rung so we can get the ball moving. At this stage, they would have only had contact with the GP and Bolton NHS Foundation Trust. But if you booked a PET scan in Greater Manchester, albeit that you might attend at Salford or at Wigan, the phone call you get is from the Christie. Hello, this is the Christie. So if you've not prepped your patients correctly, that is a frightening prospect. So what we don't want to do, though, is to delay the pathway and cause a delay in this middle part. We want to get the investigations booked and underway. So the intervention with the specialist nurse allows us to do that, but still offers the patient the opportunity to come in and to discuss what those tests involve. But it will save a significant number of days in that middle part of the pathway. And the idea is that that will speed up the diagnostic process for lung patients and allow them to move on to the specialist diagnostics and the treatment phase more quickly. Lung cancer, as we know, is a difficult cancer to treat and time is of the essence. So any impact that we can make for patients is sure to be a positive step. One of the things that we're very mindful of within this project and diagnosing patients and excluding cancer by day 28 is the emotional impact that that can have on people, which is why David and his colleagues were so pivotal in us designing the pathway and making sure that the right level of support was in, and why we invested so much in the nursing support for patients. But what we felt was a really important step was the audit work that we're going to do as part of the lung pathway, because for all of the x-rays that come through, it's a very small number that then are going to go on to a CT scan. So what we need to be mindful of is that we're not putting the fear of God into people that go for a chest x-ray, but equally we've got enough sense of importance and urgency that we pick up the cancers quickly. So part of the audit is not just around the patients that are diagnosed with cancer, but those that are suspected of having cancer to enough of an effect that we've organised a CT scan and then proved to not have cancer, and a selection of patients that after the chest x-ray they go back and are treated by the GPs, just to make sure we've got that balance right. The next diagram, and it doesn't show up as well as we would like on the big screen, but it will be in your handout. So this is just a flow chart of how those patients will be managed. It's got clear lines of accountability. It's got a clear flow chart based on the stage of the disease and those patients that would go on to a PET CT and an E-bus, and those patients who would need to be seen in clinic because they have got a disease which would require a more invasive investigation such as a CT-guided biopsy, and it wouldn't be appropriate to arrange that over the telephone. There needs the face-to-face contact. But this is a document that's gone through to the GPs for their use, for their support and for agreement, so we've got clear levels of accountability on who's managing the patients in this new pathway. So I'm just going to hand over to David. David's going to just talk through a little bit of the user involvement work with the lung pathway, which has been absolutely crucial.
Thank you, Lisa. Good evening, everybody. Yes, as part of a small team of patient representatives that were engaged to help with the whole process and the communication, really the end result to try and make it as understandable to the population of Bolton as we could possibly do so. We really had to make sure and make a judgment that there was enough information, but also not too much information, especially unnecessary information, and that the tone was the right one. It was probably the tone that was the most delicate balance. One brief example of that was buried towards the end of the original document was the word cancer. So we debated whether cancer should be raised at that point. We eventually came to the conclusion because you could reasonably expect a decent percentage of the people that were recipients of that communication probably had cancer. We decided we must keep cancer in there rather than try and bury it under the carpet. But we did our best, we hope, to advise to make sure that it was done in the most sympathetic sort of communication possibly. So in essence what we did was we looked at the entire style, wording, language, clarity, and especially the avoidance of jargon, and have been a patient representative for a number of parts for the NHS in Macmillan over the last 3 years, and there was some jargon that I wasn't aware of and didn't come across, so to the general public it's probably going to be very confusing. So we did our very, very best to try and ensure that the communications that were going to be sent out was both understandable for the local population, avoided the unnecessary raising of anxiety, but at the same stage stressing the importance of their correct action for whatever we were trying to get them to do in these systems. I think myself and my colleagues were probably quite outspoken and probably had strength of mind to understand what we felt was incorrect in the original documentation. Very much like to hope that we made the right advice, and I think that's probably proof of pudding is essentially our recommendations. I think all of them were actually taken on board, so felt very engaged and felt we did a worthwhile contribution to the whole project. Thank you.
Thanks. So we'll just move on to the upper GI pathway. So this is the pathway where we've made the least changes to actual processes, but perhaps requires the most engagement. So we've got a pathway in situ, where patients can be referred to a straight to test pathway, but we don't really use it. So the work has been around, how do we engage with GPs? How do we create more awareness around this pathway? And how do we create the support for GPs so that they know that it's safe, that they're referring the correct patients, and that those patients are safe in those pathways? So we started off by changing the documentation. We've also done a series of engagement work with the GPs with the support of our clinical leads, Melissa and her teams, to try and understand the reasons for not using the pathway. And some of it is just making sure or not being sure that the right patients are going through the pathway. So some of the assurance processes are around that the patient has a triage based on the referral information. So if they're making a good quality referral to a straight to test pathway, that referral will be triaged and anything that doesn't feel appropriate would be removed. And the patients are all seen before they go for their procedure. So there are two opportunities in which we see the patient or have interaction with the patient, which allows us to put a safety net in and move those patients to an appointment if it's not felt that the straight to test is suitable. But it is the right thing to do for the patients that are fit. That is the first line diagnostic for somebody that's got a suspected upper GI cancer. So it's absolutely the right thing to do to remove first appointments if we don't need them and let those patients go straight to test. One of the changes we have made in the pathway is an extra rapid jaundice pathway. So everyone will be familiar that patients that present with jaundice are perhaps the most sickest of the patients that we see on an upper GI pathway. But because they're not really suitable to go straight to test for an OGD, in most organisations and most pathways they would go for a gastro referral under a 2-week wait referral. In most organisations, that waiting time is between 7 and 14 days. The national standard's 14 days, so anything less than that is good. But for those patients, time is absolutely precious. So the rapid pathway is designed to see the patients within 48 hours. We've just had our first test patient, and the patient was referred on the 4th of May. They had an appointment booked automatically for the 15th of May, which was day 14 of that pathway. And the patient was identified as being a jaundice patient, was pulled out of that system and moved on to the expedited pathway. So by day 6, that patient had been transferred for treatment. So the changes and the collaborative working between radiology, booking, the CCG, the GPs, the gastro teams delivered an effective pathway for that patient. And by day 13 of the pathway, they were ready to have their surgery at the trust. So that's a really good example of that collaborative working and how we've got the infrastructure around it. It's changing the order in which we do the work with the right engagement with the right teams. One of the other exercises was around patients who are referred in on the 2-week wait pathway and are referred for an appointment. Despite best efforts, we're still going to get patients that are referred on that pathway. So we decided to hit both sides of the coin. So there is a triage process to pull those patients out that we felt were fit for straight to test. So a quarter of those patients in the trial were pulled out and moved straight to test. So that saved them time in their pathway and meant that those patients only had to come to the hospital once rather than twice. The investment has been around specialist nursing, and for those patients now that have an OGD where cancer is seen, they've got specialist nurse support at the point in which they are given the results. So that doesn't mean that they need to come back for a separate appointment where that nursing support is provided. It's there and then, it's on the day. And the process is that the patient leaves with an appointment for a CT scan. I think there's nothing worse than being left in limbo. Somebody will be in touch, we'll call you, we'll ring you, or we'll send you a letter. when you've just got a diagnosis, you need to know that something's happening and something's happening quick. So patients will leave with a CT appointment, whether that's midweek or whether that's weekend. That's the same for all of our services. And the target is to be seen for the CT within 2 working days. So they're the changes we've made on the upper GI pathway. That's live at the minute, and we're continuing to redirect and to engage with GPs to try and get our straight to test figures up to the aim, which is 70%. This just demonstrates that pathway and the speed and the difference it makes for a patient that goes straight to test. It shaves a good chunk off that pathway and allows those patients to go out for EUS and PET by day 14 with a straight to test process, which we feel is great for the patients and obviously allows a little bit more time in the pathway, either for patient thinking time or to get the treatment more quickly. I'm going to hand over to Martina, who's going to tell you about her baby, which is colonoscopy straight to test.
I'll just paint a little picture like Lisa did before. Prior to us introducing the direct test colonoscopy, the patients were being referred into the clinic, so you've got your 14 days there and then referred on for a 2-week colonoscopy with a potential of up to 28 days before they were having their procedure done. That didn't happen at the Trust, may I add. They were seen much quicker, but we still knew that the service was not fit for purpose and we needed to make changes. So we were already, as I say, looking at the pathway when the Vanguard came on board, and it couldn't have come at a better time for us. So what we did, working with the CCG, was looking at the pathway for direct test. So now the patient will attend the surgery. If the patient is appropriate for the 2-week direct test, they leave the surgery with an appointment within 48 hours for a telephone assessment with one of our nurses. The patient is then contacted at an agreed time by the specialist nurse, and they go through a pro forma with the patient. It's almost like a face-to-face clinic appointment, the information we're getting from the patient at that time. Now, the nurses that we're using, we have invested, as Lisa said, but we're using our nurse endoscopists. And at Bolton, I think we're a little bit forward thinking in how we use our nurse endoscopists. They're not just there to support diagnostics. They have all been on advanced master's level clinical examination courses and have already been supporting colorectal clinics. They have specialist roles within capsule endoscopy and anemia, and they're all expanding everything outside endoscopy as well as doing their clinical sessions of 5 a week. The next flow chart shows you exactly how we did that. So the patient will be attending the GP surgery. We work very closely with the team and the clinicians and through governance, looking at inclusion and exclusion criteria for these patients. The GP then would give the patient the bowel prep, patient information leaflet, low residue diet information and information about colonoscopy and sigmoidoscopy. They'd also, at that stage, will leave him with a consent form. 48 hours later, if not before, the patient would then be seen in the pre-assessment clinic, will then be on the telephone pre-assessment clinic. We have 5 clinics a week with 6 slots, and they all sit in line with a consultant so that the nurses do have somebody to refer to and the patients have a named consultant through their journey. The difference here is that these patients are having the consent gone through. It's a 2-tier consent, and many of you may be aware that with JAG that we should be having a 2-tier consent process, so they are aware of what they're coming for. Also that we're going through the bowel prep. That is a major problem in endoscopy, that patients are turning up for procedures and the bowel prep is inadequate. We know from our colleagues in bowel cancer screening, where the SSPs are doing the clinics, that their DNA rate and the number of procedures that aren't completed is extremely low. We're looking at less than 1%. So we know that it works, and we wanted to take on board what they were doing. Now, again, David was really supportive with us in preparing our patient information, because that was major for us in how we moved forward with this.
Yeah, so I think that the actual part of the challenge we had was that the patient information packs were national documents, so the lazy outcome would have been just to sort of like basically copied those and dealt with it. But I think we all felt that they were inadequate for our needs, so we made a very substantial change to each and every document that went out to the patient, and the feedback, as you can see here from the end of the continuance of the programme, has been very encouraging so far. I'd like to sort of make 2 points. One is, I think, well, realistically, user involvement can be seen to be either a help or a hindrance, and obviously we've got no sort of magic answers. We can only give advice as best we see fit. But certainly in this case, really, really confident that we did give our best shot at it and our best advice, and as I've said already, the things were taken on board. And I'd also like to say that it's not just about processes and systems, and if I may say so, what I saw at the Royal Bolton was an immense amount of passion and commitment, and the openness and willingness to change and to improve, even though their figures and their systems sort of like beat others in many respects. So I think that's a really encouraging thing, and it's great to be involved in such a project. And so it wasn't just sort of like a tick box exercise. We were heavily engaged and moving forward, just being told we may be sought our advice again regarding audits and so forth, which we're very welcome to do. Thank you, Lisa.
Lovely, thank you.
So we've been very lucky. We've actually gone live.
Yeah.
We went live on the 3rd of April. And the patient feedback we've had has been really, really good. First patient actually said they'd had this procedure done before, they'd had nothing like this, they felt they were fully informed. Again, it was fast, safe, excellent service, and that continues with the information. We're continually auditing this project, and again, on weekly basis, fortnightly, with our meetings. Of course, there's been teething problems. There will be teething problems. It was a slow start from the GP practices referring into the system. So we're going to pick up on that later on when Melissa is speaking about the issues that we've had with it. But what I wanted to share with you really is a snapshot audit of the first patients into the service between the 4th and the 29th of April. 17 patients, yes, a small cohort, but it is growing. 6 patients has had the procedure performed at the time that I looked at this audit, and 1 cancer was detected. Prior to this service being introduced, the traditional, coming in through the traditional route, the average time to colonoscopy was 18 days. The average time now is 8 days, and that is all those patients that we've got through, and it is continuing. I can update you with the audit information that we've been doing now. So here's a timeline of our cancer patient. So her consultation was done in clinic on the 19th of the 4th, telephone assessment, directed test. She had a colonoscopy on the 25th of the 4th. She left with her appointment for CT scan, thorax, abdomen and pelvis, and at that time the colorectal nurse who has been employed on the back of this pilot came to see the patient. So all patients are being seen either at that stage or within 24 hours they will be contacted by a specialist nurse, and that's the same for upper and lower GI. MRI pelvis rectum performed on the 29th, same as the CT. Colorectal MDT 2nd of the 5th. Outpatient appointment 3rd of the 5th, and this patient had to go back for a second colorectal MDT. I'm pleased to say that she was seen at the Christie on the 9th of the 5th, and she was capped across here on day 25. So we are seeing positive, really positive results. Since I put the presentation together, we've had a second patient. Telephone assessment on the 28th, just prior to the bank holiday. Colon on the 8th of the 5th. That was a low colorectal tumour. CT, MRI, 11th of the 5th. MDT, 15th of the 5th. 17 days. And that patient was seen at the time of diagnosis, provisional diagnosis, by the specialist nurse. Obviously, there were some teething problems, as we mentioned earlier. The GPs were using the incorrect referral form. Patient information leaflets might not have been given, and a number of patients are still not being informed by the GPs that they are on a 2-week wait. All patients received the prescription for the bowel prep, but this has been quite a stumbling block for us. But again, as I say, moving forward, we have issues to overcome with the GPs, bowel prep, communication, communication, communication. That is the most important thing, and those channels of communication are so good with our colleagues in the CCG. That's what has made the difference. Continue with that collaboration, continued audit, and change along the way. we have changed already. We will be sending the bowel prep out now from the Trust because we know that the turnaround time, it gives us time to get that bowel prep out. We have to meet our colleagues in the CCG halfway, but we have to remember what this is about. Patient first. The data is proving that this works, and we must always keep that at the centre of everything that we do.
So in terms of engagement with primary care, we've led on that from a CCG perspective, and we've also had Dr. Tarek Bakht, who is our clinical lead for cancer, supporting on that from a GP perspective. We've been using existing CCG forums that have been established. So we have a monthly meeting with the clinical leads from each of the 50 GP practices. We also engage with practice managers as well, which is sometimes overlooked. But for us, the administrative side of this pathway in terms of ensuring the patient leaves with that telephone assessment appointment, they leave with the patient information, it was actually pivotal for us that practice managers engaged with that. And actually, we did find that in some feedback we've had from practices, the practice managers have been encouraging the GPs to use the pathway and reminding them that it's there. So they've been a really crucial group. And we've also engaged with, through our informal LMC meetings as well. And as Martina said, we did get some feedback from GPs that for them to issue the prescriptions for bowel prep would be quite challenging in terms of to do that in a 10-minute appointment. And also the questions they were then getting from the patient regarding the bowel prep, which is why we've now revised that process based on feedback from GPs. It's also been really critical that we've progressed all of this officially through CCG governance. So even though we have governance through the Vanguard, a lot of GPs will not recognise this pathway until it's been taken through our clinical standards board. So that's been really valuable. And also promotion, so we've been putting it out in our regular GP newsletter, and also direct comms through our GP clinical lead as well, because a lot of those catch-all regular communications do get lost in very busy email inboxes. So lessons learned from where we are now. In hindsight, I think we should have begun GP engagement at an earlier stage, so we had actually worked up the pathways and then went out to engage with them when we had a go-live date set. And in hindsight, perhaps we should have involved the wider GP membership more in co-designing these pathways. The formal endorsement through CCG governance has been really important. So we're taking direct test colonoscopy to our clinical standards board next Monday, and we therefore hope that the uptake of GPs referring into that service will increase once it's got formal approval. That support from clinicians involved in the CCG, so clinical directors, clinical leads, that doesn't always represent your wider GP membership, and actually engaging with wider practices was really important. Being willing to listen and adapt, so the pathways absolutely hinge on the GP supporting this. There is no point us having these fantastic pathways if no one refers into them. And actually the standard 2-week wait pathways are quite comforting, they work, they're there. So actually it takes quite a lot to encourage that behaviour change, and we've had to work really hard to find neutral ground and be prepared to compromise. As I said earlier, engagement with practice managers and admin staff on some of the logistics, and making change as easy as possible. So one of the really small issues that made quite a difference on the lower GI was putting all the patient information into one document so that the GP or the practice staff only have to open one document and print that out, whereas before it was 3 separate documents. And whilst that sounds like a really small change, that makes a big impact in terms of freeing up those crucial seconds in primary care. And as you've heard from David, patient engagement has been critical for us in terms of getting these pathways right and ensuring that patients engage with them as well. So what's next for us? I think you've gone too fast. Sorry. So we intend to relaunch the direct test colonoscopy pathway with the new process for issuing the bowel prep. We just need to do a formal sign-off of the lung pathway through CCG governance, and then we'll be ready to go live. Further engagement events for upper GI. And for us, which I think has been a really valuable learning curve for me from a CCG perspective, is how much the FT focus on auditing this and monitoring it. And I think we're really keen to ensure value for money and sustainability of this service if it works beyond the pilot, hence why the auditing and the evaluation is really important, also for us to share that learning with other regions in GM. And also, a year is not a very long time, so we are rapidly approaching a point where, as a CCG and as the FT, we need to start discussing what our options are for continuing beyond the 1-year pilot once the Vanguard money expires, and whether we would adapt them, whether we would adopt them in their current form, because if they're providing the results we see, really we'd be daft to not continue with them.
And that's everything. Thank you very much for listening. I hope that what you do gain from this is that whilst this is a project about making diagnosis quicker, and if that becomes the new national standard, it's something that will be monitored again, so it's absolutely important that we've got the ability to roll this out and upscale. But hopefully what you can see is that the patient has been at the heart of absolutely everything that we've done in making changes, and every change that we've made, we've done because we believe it's the right thing for the patients in a cancer pathway. I think every single one of us that's involved in the project has in some way been affected by cancer, either us, friends, colleagues, relatives, and it brings it home. This is about individuals, this is about the care that people get in Greater Manchester and in Bolton, and it's about providing not only timely access, but the support that patients need to cope with that referral and that outcome. So hopefully the work that we've done will contribute to those improved pathways. And we're open to questions.
I think we have a few minutes for... is this working? Will you hear me? A few minutes for questions if people would like to put something to the panel. David?
Hello, it's not a question, more a statement, and it's something you've touched on already. But one of my obsessions, if you like, is communication, or the lack of communication. And as soon as you've got several areas involved, then it falls down. I mean, this is a bugbear within the NHS, as we know, and I'm not being funny about the last few days. It's a continuing thing. Just to illustrate this, I was talking yesterday to a lady from Bolton who'd been involved, obviously, with Bolton, Fairfield. I was talking to her at the Christie at Oldham Radiotherapy Centre, and the fourth part of the equation was the GP. And one of her comments to me was that she wished she could deal with one person. Now, don't shoot the messenger, I'm just reporting how she felt. She found that when she asked a question about at B, about A or C, there was often a blank face. They didn't know, they hadn't received it yet. So I would suggest that communication needs constant vigilance and audit.
You're absolutely right. And if you are a patient, a carer, a relative, anybody involved in that pathway, not knowing the next stage, not knowing who to go to is one of the worst feelings, and I know that from personal experience as well, which is why part of the project invested so much in the nursing element, the specialist nurses that are there to support the patients. Because whilst there is absolutely no way that we will go back to organisations delivering everything. We've got specialist centres that are geared up to deliver very complex and very difficult treatments. So patients do span across multiple organisations, but it's important that there is a continuing element of communication. And for me, in our organisation, that's the specialist nurse. That's the specialist nurse that's assigned to the patient, the key worker, right at the start. And there is a transition across organisations, but that should be the one static thing, and that's important that we get that right. But it is important that we recognise how patients feel across those journeys and learn from that. I agree.
Anybody else?
Hi, thank you very much. It's very interesting. Congratulations on the progress you've made so far. I've got two questions, really, separate ones. The first is that I guess we all know that a lot of delay in diagnosis is not in the area that you've been talking about today. It's the patient actually getting themselves along to see somebody about an issue in the first place. And I mean, I know other bits of the Vanguard, and there's other work going on in Greater Manchester about those sorts of things, but I wondered what you thought about that and how relevant that is to the work you're doing. And the second thing is, don't take this the wrong way, because it's great that you've made this progress. But 28 days is actually still a long time. If it was me, I'd like to know next week. In fact, I'd like to know today, but I recognise that perhaps isn't possible. But 28 days is still quite a long time. And having done the work you've done so far, and clearly you're making loads of progress, how ambitious can we be? Because 2 weeks would feel better. And I would bet that in some parts of the private sector, that's what you would get, where there isn't a queuing issue to be dealt with. So I just wonder what you thought about that.
Can I answer the bit about the time? Is that all right? So as part of the reason that the target is set at 28 days is because that's anticipated to be the new guidance that they're talking about nationally in terms of find out faster. So that's looking at 95% of patients being diagnosed by day 28. There is a middle marker in there to monitor at 14 days, so that's exactly what we'll be monitoring and what we'll be auditing against and what we'll be reporting against as well. So we'll be monitoring the 14-day standard and day 28 as well. I think what we do need to recognise is that there is a difference between the date in which a patient is diagnosed and the date in which a patient is told as well. And that's two different parts, because for a patient that is diagnosed with cancer, they usually find that there and then. And for patients without cancer that are having a scope, they would find out there and then. But there are tumour sites where patients may have a test that's sent off and then they're brought back to clinic. So it's not always the same day that the results come back, and that's something that we need to pick up as part of this audit as well, the patients that are not diagnosed with cancer and when they're told. So all of our analysis will be we'll be doing day 14 and 28. Internally, we'll be monitoring from day 7 as well, because actually for us, there will be a cohort of patients that will be diagnosed way before day 14, and we want to capture not that they were diagnosed by day 14, but if that's by day 8 or day 7, that makes a difference to that patient and that patient's family. So we'll be monitoring it by each individual day, but we went with day 28 in terms of what the national guidance is expected to be, so we can fall in line with whether this pilot has allowed us to deliver that standard and what other work we need to do to support patients. But you're absolutely right, 28 days can be quite a long time. In a lung pathway, for a patient to have a formal diagnosis with histology, they quite often need to have a CT, an EBUS, a PET scan, all of which need to be done in sequential order. So that's not unreasonable at the moment, that those pathways do take that amount of time. So it's absolutely right that we focus on the earlier milestones. And I think from the information that Martina presented and those pathways, we are well ahead of the 28 days in some areas. And absolutely that's the ambition.
And I think if I pick up around obviously, this is critical to patients presenting to a GP or another medical professional in terms of identifying those signs of cancer, and we do a lot of work as a CCG and working with the Trust on screening, but also on the wider signs. So we did a big campaign in Bolton a couple of years ago around lung about persistent coughs and to go to your GP, and obviously that feeds into a lot of the work that Greater Manchester Health and Social Care Partnership are doing around prevention and awareness. I think for us another critical issue is obviously supporting GPs to identify potential red flags for cancer, to refer them on to 2-week wait in the first place, because there's no point us having all these brilliant diagnostics if actually the GPs aren't necessarily recognising that they need to go onto a 2-week wait pathway. And we're really pleased that our GP clinical lead for cancer is also our education lead, so they go hand in hand. And we're also an early adopter of the Gateway C Cancer Education Project, which is another Vanguard project, and 2 of their current modules are around lower GI and lung, so that really works nicely with this in terms of us trying to encourage GPs to be more confident in referring patients onto 2-week wait pathways, because for some GPs cancer is one of about hundreds of other options that a patient could have.
I think what's really important to just add to that is, because of the working relationship we have, we don't work as a foundation trust and a CCG. We work in partnership, so we meet once every 8 weeks approximately, and part of that meeting is to discuss things that our clinical colleagues have raised. So we have a cancer board at the Trust that meets every 8 weeks as well, and our clinical colleagues will bring to us any issues, any queries about referrals, anything that they've felt inappropriate, anything that they've not felt is highlighted enough in the referrals, and we feed that back to the GPs via Melissa and her team. But we feed back at GP level, not just these are the themes, these are issues that we've picked picked up. Our clinical colleagues will take the time to explain to the GPs where they feel that the process has gone wrong, where they feel that they should have highlighted something that's very important that wasn't detailed enough in the referrals, or where a referral's inappropriate, and what things that it should be doing, and we'll support GP engagement events, which everybody is here to do the right thing for patients. And you're absolutely right, it's about GPs presenting and recognising those red flags, but we've got the specialists in the organisation as well that need to support the GPs.
I mean, actually, it is about GPs recognising. It's also about patients getting themselves
Yeah,
to GP
of course.
in the first place. And I sort of suspect that's where a lot of the delay lies.
I think we've also got the national, for lower GI, we've got the National Bowel Cancer Screening Programme, and we're very happy to share our information from Bolton, being the site for Salford, Bolton and Wigan. We've also gone live with BowelScope, and that's a non-symptomatic group at 55, but obviously that's not been... there's not a lot of education out there at the moment because not every site has gone live, so until we do, we won't be publicising that as much, but the audit data is going to be very interesting once we get all the BowelScope lists up and running as well. But again, it's about patient identifying, you know, the patients themselves coming with those symptoms or not symptoms, and engaging with the national surveillance programmes.
Sorry.
Yeah.
Melissa, I know you touched on it, but is there intention, and do the timelines work for the pilot to cease, but actually it to become steady state, or do you see a time lag between a pilot finishing and something being commissioned and adopted? So is it going to be a continuous run-through? Is that the aspiration?
From a commissioning perspective, it should be a continuous run-through, because I think we risk putting out confusing messages to GPs and to secondary care colleagues and to patients as well. If we say, we had this pathway, it stopped, everyone go back to normal 2-week wait, but in 2 months' time, we're going to start it again, which is why we're really having those conversations now to ensure that the work we've done, we don't lose any time with that. So we would see it being something continuous from a commissioning perspective. And I think we have the capacity within secondary care to be able to continue this.
And would you be able to continue the evaluation of that then for lessons and sharing, because it just builds a more powerful case, isn't it, for others to adopt?
Absolutely.
Yeah, brilliant.
Couple more questions, I think, if we can.
Thank you very much. I'm probably the only head and neck surgeon among the audience. Thank you very much. I congratulate you for the excellent work. You covered part of the problem. We discussed the primary care issues, but also what happens after having a CT scan or a biopsy. You have the laser reporting, there is a pre-assessment, getting to MDT. So if we really need, if patients in the center of our focus and early diagnosis, better prognosis, if we are going to audit the impact of your initiative, it should also look at the whole journey for the patient, not only that stop by how many days. For example, we reduce it from 18 days to 8 days to get biopsy, for instance. You need to look at capacity for theater, patient getting to their treatment, definitive treatment, and the impact of all of this on the journey. Thank you.
You're absolutely correct, and there's absolutely no point in diagnosing a patient's cancer earlier if there is no better outcome for the patient. Absolutely accept that. The audit work that we will do will cover not only the elements that are part of the project in terms of how many patients are diagnosed by day 14, day 28, but what that means for those patients. So do they go on and are transferred earlier for surgery? How does that translate to the trust that are receiving those patients? Because unless it's patient choice to have thinking time, what it shouldn't mean is that we send the patient out on average, say, 10 days earlier than we were doing, but it takes 10 days longer at the treating trust. And that's absolutely not what Greater Manchester is about at all. We've got very, very, very good collaborative working between organisations. The organisations that deliver those pathways in conjunction with Bolton are all signed up to knowing what this project is about, the audit, the management of those patients. I sit on the Cancer Managers Forum, so this is a discussion item at the Cancer Managers Forum, and the audit will include the patients that are transferred and treated externally from the hospital and what the outcome of those pathways are, because part of the analysis is around what do patients want out of this. Does it give them a little bit longer to kind of take a step back, have a reality check and decide what they want to do? Or is it that that gives patients the opportunity to have earlier access to treatment? We think it's probably the latter and that patients will want to move those pathways on, but that's part of the analysis and how does it impact on patients having that expedited pathway at the front. But we do need to make sure that it translates out to the end of the pathway as well.
Time for one more.
Just a practical question about radiology. I noticed you reported on time to scan, but what about scan to report available? Often that's a delay in pathway. So was that a problem for you? And if it was, how did you overcome it?
Okay, I think the challenges on every organisation in Greater Manchester are similar in terms of diagnostics. Our reporting times are good in comparison to peers in Greater Manchester. It doesn't mean that we don't struggle with the same problems. What we have got is a very collaborative approach with the management of cancer pathways. We do use some flexibility within the system for extra lists, extra reporting sessions, as most organisations will do, and some external reporting systems. For us, the cancer pathways are managed on site internally. We have a radiographer that is part of our core cancer performance meetings that meet to discuss every patient on every pathway twice a week. So that allows us to manage those pathways as effectively as possible and to highlight where there are delays, and with an appropriate trust-wide operational policy for the management of timelines. Don't get me wrong, there is times where in sickness, annual leave, bank holidays, Christmas that happens surprisingly every year, but there are issues around that, but we've got every process in place that we can do to manage that as effectively as possible. Internally, we report on our turnaround times for CT and MR for cancer patients. And we report not only as an average, we report as a medium weight, and we report by tumour site as well. And that gives us the overview to monitor and adapt to any change where there's problems. The one thing that I would say is that sometimes your average reporting times can skew things ever so slightly. There is little point in me begging a radiologist to make a report on a Friday if the patient isn't going to be discussed until the MDT on a Monday. And we have to be realistic in how we manage the resources. So sometimes a report might on a piece of paper say it took an extra 2 days, but if that is the place where it is the best place for that patient discussion to take place, then that's the most appropriate use of resource. So we use our twice weekly meetings to manage that, to try and make sure that we're using the resources as safely and as appropriately as possible to manage those pathways. Because you're right, there is absolute pressure, in particular on endoscopy and radiology in every organisation.
Thank you very much, I think we've covered everything. Thanks very much indeed, Lisa. I think that merits at least another round of applause.